Hi, everyone.
Hey, Rob.
Hey. So, welcome to room one. We've got a very interesting case I want to share with you. I first want to just introduce you to everybody who's joining me here in the room. To my right is my friend and colleague from vascular surgery, Dan Hahn. To Dan's right is our stellar fellow, Lindsay Thornton. We've also got an unbelievable team here in the room. We've got Donnie, our nurse, taking care of the patient, keeping them safe. In addition, we've got an amazing anesthesiologist, Ryan Tufts, and our great technologist, Latchme. So everything is really set up, and we're happy to share this very interesting case. We're going to talk about venous occlusions, venous stenting, venous compression, intravascular ultrasound, a whole litany of different issues. So without any further delay, I apologize for the AV issues we were having before. I'm going to ask Dan to my right to present the case presentation. He's been following the patient for certainly much longer than I have.
Good morning, everybody. So this is a 46-year-old female. These are the disclosures. Next slide, please. Oh, next slide as well.
Next slide.
All right, so here's a 46-year-old female that we've been following for a couple of years. Initially presented with a fibroid uterus and left lower extremity swelling. At the time, had a C5 active venous ulcer. Her ultrasound findings were no superficial venous reflux, positive for deep venous reflux, and had left external iliac vein occlusion at the time of the initial presentation. So back in October of 2014, she ended up getting a stenting of that procedure. This was early in our venous stenting experience. She ended up getting a smart stent, 14 by 280s that were overlapped. And we can talk about the different venous stents as we talk throughout this case. Not unsurprisingly, perhaps, a month later, the entire stent system had thrombosed. So she ended up getting a thrombectomy as well as a high-pressure balloon angioplasty of that entire stent. And she had done very well since that point. So from November until November of 2014, she went on to heal all of her wounds, had been compliant with her compression, and over the last couple months, she has unfortunately redeveloped a new active left medial malleolar ulcer as well. So she comes to us today as C5. So if we go on to the next slide, we can kind of see some of the slides from the original procedure. Let's go to the next slide. Keep going, please. Next slide. So this is the initial intervention. You could see that she had an occluded left common iliac vein, which ended up getting a stent. At the initial presentation, looked okay, but you could see the classic findings during a venogram. You got pancaking and no visualization of the left common iliac vein, extensive collateralization through the internal iliac vein system that had almost resolved after the original stenting procedure and looked reasonable. Next slide. So looks like we don't have the November slides up here when she had come back thrombosed, but she ended up getting the thrombosed stents thrombectomized and then high-pressure balloon angioplasty, and she had done okay. And then we talked about how she went on to heal those wounds afterwards. And now this is her CT venogram from earlier this year. You still see her uterine fibroid. She had undergone one UFI procedure for that. But if you look at that left common iliac vein stent, there's two things that we know. Number one, it's extending way up into the IVC, and the controversial topic we'll talk about. And then as it comes into that standard area for May Thurners, you see significant external compression. It had not thrombosed, but you do see some lining within the actual iliac vein stent itself. And after this stent, after this CAT scan, with the appearance of the new ulcer, we find ourselves here today, here for the procedure. Next slide. So in summary, 46-year-old female with May Thurner syndrome, persistent left lower extremity swelling and worsening medial malleolar ulcer with surrounding erythema. We have suspected narrowing of her indwelling left iliac vein stent based on the CT venogram findings. So our plan is for a left lower extremity venogram, IVUS with possible angioplasty and stenting.
All right, Dan, thanks for that summary. So we've got a lot of stuff going on here. We've been working feverishly to try and get the case ready for you guys. Can we show the first venogram, please? So as you can see, we have bilateral sheets in the common femoral veins, and we have wires up. So here's our initial access venogram. And of note, if we could just keep on cycling that, there's significant in-stent restenosis in the external iliac vein, which is not necessarily where I anticipated seeing all the ISR, although the CAT scan certainly suggested that. Again, it's important to note that the original stent goes way into the IVC, and that's just a 14 millimeter stent. Next venogram, please. We did IVUS, and I'll show you the IVUSs in just a moment. Next venogram. We access the other side, and of note, again, you can see the left common iliac vein stent going into the IVC, and, you know, not to be blunt, but it's really jailing the right common iliac vein. You see a little bit of reflux into the right internal iliac vein on this venogram. Next venogram, please. Here's a bilateral shot, just to give you an idea of what the flow dynamics are. And then one more venogram I think we have. All right, and then we did ballooning while we were off camera. But what I'd really like to do is show you guys the IVUS, which I think is going to be really helpful here. So if we could switch over to the intravascular ultrasound, that would be great. And so this is the run through the left side. So if we could play that. So obviously we're starting high up in the IVC. And as we start to pull back down, you're going to see the stent getting pressed down right there, which is, in my opinion, moderately significant. You have ISR throughout the distal common iliac vein, and then I'd say pretty severe ISR in the external iliac vein, going all the way down to the common femoral vein, where it ends up looking certainly a little bit more normal. Next IVUS run, please. This is just a higher magged up view, so if we could cycle through that, just to give you guys just a little bit of a picture about that compression point, which is at the iliac vein confluence. So again, the stent here in the cava looks good, and then as soon as you get down, it's being compressed significantly. It has that, you know, sort of elliptical shape. It's not a cylindrical shape, and then again the ISR. And we have a run through the, which is the last IVUS run on the patient's right leg, which we'll show you also. That's run 4. Thank you. So this of note, and this is mostly to be provocative.
This was post-angioplasty.
Is to, sorry, can you show run 3 on the IVUS? That was the left side again. I apologize. So here we go. So now we're in the IVC, we're pulling back into the right side, and we're actually outside that caval stent here, which you'll see in just a moment. Right there, we're coming down, we're outside the stent, so we're actually able to pass around it. So I'm interested to hear what you guys want to do with this case at this point. And then the last thing I want to show everybody in the audience is this ulcer, which again, you know, people say there's ulcers and there's not, but if you could zoom in right here on this patient's ankle, if that's possible. You know, I hate to use the proverbial "a picture's worth 1,000 words," but you see that there's a real ulcer here. This is the real deal. Okay, I think you guys can see that. And so this has been, you know, sort of fluctuating. It was healed, and then it's gotten angry again, and we're in that phase where it's just not progressing well. We did the CAT scan, it showed ISR, and now we have venograms and intravascular ultrasound, and we're looking to the panel to help guide us with what to do. I have my own opinions. You know, Dan and I have been talking for the last 15 or 20 minutes, but I'm very curious as to how you guys would approach a case like this with a very symptomatic patient, a number of abnormal findings on the ipsilateral limb in terms of the iliac veins, in terms of compression at the confluence, ISR in the external iliac, and then obviously the findings on the right side in terms of the issue about the right side being jailed. So I'm going to open it up to you guys.
All right. I think there's a lot of things going on here, Rob. So one question I have before I start giving my at least recommendations is, what is the infrainguinal venous system like on that side? Because, that's a pretty severe ulcer. Generally,
Right.
and I'm just curious, in terms of inflow that we're going to be working with once you're done with your intervention.
So my understanding is that this patient has mild, deep venous reflux
Okay.
in the infrainguinal circulation. It's not, substantial, but the patient's also undergone stripping, ablation, what have you, of the superficial system.
Okay.
So we're really dealing with, from my humble interpretation, a deep venous issue right now in a patient with a problematic healing medial malleolar ulcer.
Right. All right. Well, I guess, and we can certainly go down the panel and then love to hear what you have to say. I think that, in-stent restenosis is really very difficult. Obviously, with nitinol arterial stents, that basically flattening of the stent is not surprising in the areas of greatest constriction. So you have both a mechanical issue where it seems inadequately stented, and then you have all of that in-stent restenosis. I think that, my brief recommendation is I would have this patient, therapeutically anticoagulated, prior to and during the procedure with Lovenox. I would plan on treating with hopefully one of the newer venous stents, dedicated venous stents that may have less, crush resistance and better resistive radial force. So I would do aggressive angioplasty. I would use one of the new dedicated venous stents and have anticoagulation and antiplatelet therapy, which, again, there's no right answer for that, but that's my preference. And then as far as the contralateral leg, I know that there would be potentially an interest at also revascularizing that, maybe again with one of the dedicated venous stents, but I don't know that my hand would be forced in an asymptomatic limb. I'm not a fan of treating the picture because, as you know, there's a very low threshold out there for venous stenting. And so if it's a truly asymptomatic limb and basically your cava is normal, I'd make sure I land that dedicated venous stent just, just slightly above that greatest area of restriction. And I would not treat the contralateral limb. That's my 2 cents.
So I'm very, very closely aligned to all those recommendations that you said. I'm curious whether anybody else on the panel wants to chime in about this.
This case underscore many important points related to venous stenting. If you look at the initial films, you'll notice that this patient has a very high IVC bifurcation, the confluence. Instead of the usual L5 location, the bifurcation IVC is actually located at L3. So in these cases, IVUS is really important to pinpoint where the origin of the left common iliac vein is. So even if you have to put the stent into IVC, you don't put it too much into IVC. And this is where the new stent will be really valuable, because with a new stent, you don't have to project the stent into IVC. You can put it right at the orifice. With that, it may have avoided some of the issue related to this case. I want to echo another point, and that is that it's pretty unusual to see venous ulcer with deep venous obstruction alone. These patients almost always have concurrent superficial venous disease. So I will look carefully in the calf with ultrasound, maybe yourself, to see whether there's a perforator, whether there is some vein that you can close. So it's very likely that if you just stent in this patient, that alone will not close the venous ulcer in this patient.
I agree with that, actually, Rob. This is Kush. So in addition to what Keith said, I wouldn't really worry about the contralateral jailing. There's retrospective data to both effects. I think one of the multi-center trials out of Europe that Jerry O'Sullivan ran showed that it wasn't the risk factors associated with contralateral DVT were surprising ones, like unrecognized internal iliac DVT on that contralateral side. It wasn't the contact with the contralateral cable wall. It wasn't complete obstruction of the right iliac vein orifice or any of those things. But to echo what Windsor says, I would say, yes, you need to look at the ulcer bed because you'll find refluxing varicosities underneath it. And after dealing with the deep side, you can just foam the ulcer bed and really speed up the ulcer healing.
So I totally agree with you, and I just want to sort of paraphrase and maybe turn around the comments that have been made. Would anybody, given the ulcer, and I totally agree that this is not a isolated issue leading to this patient's ulcer, would anybody leave this central venous finding alone and not treat the left iliac veins?
No, we wouldn't leave it alone.
Okay, everybody would treat this in the setting of a technical failure. Is that agreed upon?
That's what I would do. But the other thing is to emphasize is that when you dilate these stents, it's a super dilated. So if it's 16 stent, I will use as 18 balloon at the minimum to really enlarge the stent. And if you look at the earlier film of this patient, there was some area of compression. So if you have dilated the stent initially, you might have avoided some of the issue. But certainly when you take these patients back for a second look, it's really important to super dilate the stent. If it is an 18 stent, millimeter stent, you will use an even bigger balloon to make sure the stent is fully expanded.
One thing I would
All
say,
right.
Rob, just real quick, is
Those are awesome points, Windsor. What I want to do, just 1 second before we go on, is I want to get the IVUS right up to that point where it's maximally compressed, just to sort of start the conversation about where you guys think, if we're going to re-stent this with a newer dedicated stent, where we should go. So right there is about where the stent's being squashed. I think you guys can see the IVUS there, all right? And so we're literally at the bottom of L4. So my question for you is, first and foremost, this is a 14 millimeter smart stent that was placed several years ago. We know where the compression point is. How high would you go, and what diameter stent would you use?
I would go about a centimeter or two above this at most, and I would actually probably just go with the 14. And if you look at the European experience with these dedicated venous stents, which is considerable compared to ours, which is nascent, I don't think you need to oversize this a lot. I mean, this guy has mild deep venous reflux at this point, and a 14 millimeter stent that is fully expanded, resolution of the compression at the iliac vein compression site, and then obliteration of that peripheral rind of in-stent restenosis, I think will be sufficient to treat the deep venous set. I don't think you need to go bigger than 14, at least in my opinion.
Rob,
Okay.
two things.
Anybody else?
Did you?
Sure.
Did you do pullback pressures by any chance?
No, we did not. I am happy to do that, but we have not made it a routine with these findings of compression and reflux to do pressures. I'm also not. I've my own idea what I think the gradient would be to be the threshold. But I think because the patient's so symptomatic, I think no matter what, we're going to re-intervene here.
Right. The one thing I was going to say, Rob, is because this can be a very slippery substrate, the in-stent restenosis, I would personally do aggressive angioplasty as you have prior to placing my new stent. So when I post-dilate, I don't see any movement on that. Even you can see that watermelon seating with these new stents also once you post-dilate.
So again, I want to take a poll because I want to start moving this along. Would people prefer to put in a 14 millimeter implant here at the compression site, or a little bit larger, maybe a 16?
Could we get a measurement of that compression site?
Sure. So if let's go. I just want to go a little bit farther down to here. Okay, let's measure it here. Can we get a measurement here, guys? So we're gonna measure it for you while we are live. So this is obviously more distal. So this is the common iliac vein. I think we should go a little bit wider than that, guys,
You want to
into
look
the bottom
outside
edge.
outside the
Yeah, the rind of
ISR.
ISR. So we're gonna readjust that.
16.
So on the first go around, with wall stents, we use an 18 millimeter wall stent for a man. For a woman, 16 millimeter. With the new stents coming down the road, the sizing is a little different. Probably a 16 or 14 will suffice. So it depends on what stent you'll be using for the case.
So that's our measurements. I think you guys can see it. I think that's a fairly accurate measurement of the common iliac vein. So what do you guys think? 14 or 16?
Actually, I'll reverse. I'll go with the 14 there.
Okay. So what I think we're going to do, to everyone's point, we're going to dilate this whole segment with a 14 millimeter balloon. We can talk about, how you want to, how much coverage that we want to get. We can go back to the venogram. And then I'm going to start pulling some stents. We'll hopefully get this case wrapped up in the next 15 to 20 minutes or so. Okay?
Yep.
Rob, why not just dilate this lesion and see what happens? Why another stent?
So my concern with this case specifically is the level of compression that we've demonstrated on IVUS at the confluence before. And I don't think ballooning is going to alleviate that. I think we've sort of touched upon this, that we have a relatively low radial force stent that's at the confluence. It's being squashed. We ideally want it to be cylindrical. And we think that at least on the proximal portion towards the iliac vein confluence, we want a high radial force, crush resistant, dedicated venous stent to land in that position. So at a minimum, I'm leaning towards stenting the common iliac vein. I'm a little bit more open about the external iliac vein, but I value everyone's opinion on the panel. I thank you guys enough. You guys have been giving me great advice so far, and I want to sort of open it up there.
I mean, I think that if you're going to end up treating this with a dedicated venous stent, my preference would
We
be
go to the live fluoro, please.
common iliac and then through the ISR down in the external with a dedicated stent, because you had extrinsic compression down there as well. Not as severe, but
Can
you
we
had
switch to
definite
X-ray,
flattening.
please? So I'm going to mag up. So you guys see that waist there? So there's a couple of very interesting points. One is that I think that the previous comments about pre-dilating are absolutely critical here. And I think you're seeing that there's a real waist in the stent, that we're obliterating it to pre-dilate it, and this, we hope, is going to allow the new stent to land more favorably. And so what we were saying is that we were going to land the stent about a centimeter higher. I'm thinking that we're going to take the stent and take it right up to the transverse process there of L4. And so now as we're pre-dilating the entire length of this stented segment, and you can see the ISR with this sort of soft tissue rind, since we now have obviously long single implants, we've got 14 centimeter stents, in length. Would everybody on the panel put a short focal stent at that compression zone, or would they essentially reline the entire segment?
I would reland the whole segment.
I agree, and
Okay.
I think
Long
that we
stent.
talk about cost. I think that it's becoming, as you know, Rob, a bigger and bigger issue every day. I think one stent you'll be able to solve this with a long stent.
Excellent.
And unlike the wall stent, a longer stent will have the same radial force at its edges as a shorter stent, whereas that's not true of what we've been doing for 20 plus years. Where a short stent, we can foreshorten, and the diameter is a function of its length. So
I need a 14 by 140.
Now, I want to bring up another very important point here. So the stent here in this particular patient extends from the external iliac vein to the common iliac vein into vena cava.
14 by 160.
Always look distal to the stent, because sometimes there may be a lesion there that you miss on the first go around, or the patient develop a new lesion since the stent is placed. So when in these cases, it's very important to make sure you introduce a sheath it's as far distally as possible. These are some of the cases where you want to put the sheath in the femoral vein. So you truly visualize the entire common femoral vein and the distal external iliac vein. Don't assume that the lesion is in the stent. The lesion may be distal to your previous stent.
As that fluoroscopic image just showed, right there, down.
Right.
distal
So
to-
Windsor, that's an excellent point. So there's two things. One is that we've actually pulled the sheath back almost 75% out to make it so that we're just barely into the distal common femoral vein. The stent that we've chosen here, just to walk everybody through this, is the new barred Venovo stent. And we've been pre-dilating the lesions with Atlas balloons, which are barred balloons, obviously. And so the point that Windsor's making is a critical point. Inflow is absolutely paramount here. And there's two issues. One is that the venograms were not with the sheath in the external iliac vein. The venograms were with the sheath in the common femoral vein. Secondly, we have the CT venogram. And I know that's not the gold standard. We all believe that IVUS is the gold standard, but we have the CT venogram that shows that the left common femoral vein was of normal caliber. It measured about 14 millimeters in diameter, 12 to 14 millimeters in diameter, and there was no evidence of synechiae, chronic DVT, certainly not acute DVT in the common femoral vein. So from that perspective, I feel comfortable with the approach that we have, which was a common femoral vein access. We're very, very distal in the common femoral vein. Our venograms have been trying to visualize the entire length of the common femoral vein. You can see there the sheath is right at in the middle of the femoral head. You can even see there's actually reflux through the inferior epigastric vein there. And so now we have one stent. We're going to try and see if we can do this with one stent. It's very elegant now, just to call this out, that we can do this whole case with one stent. I think it's a very sophisticated way to approach this, to Keith's previous comments. And now I'm gonna ask the panel about how high we should go. And we're going to zoom in on the top part. And so here we are. Now remember, the compression zone was at the bottom of L4. So do people feel that we're in a good location here? Should we do more venograms from a contralateral injection? Should we pull back a little bit? How do you guys want to land this?
Based on the angioplasty that you did before, I think you have a small amount of room to come down a bit, not much.
Okay.
Because down at the bottom
Like about
of the
3 or 4 millimeters,
yeah,
right?
because
right,
down
right,
at the
Keith?
bottom
Okay.
of the stent, you're just going to be, if you keep it where it is, you'll be a little shy on the bottom, closer in the external iliac. So I think that looks pretty perfect to me.
So,
Okay, all right.
so there's some spreading out of the proximal ends and distal end of these stents. So in particular,
Correct.
in this case, I probably would leave it just at the original previous stent, maybe even slightly more distally. This is a young patient. She's 46 years old. So
Right.
I won't be surprised. So at some point down the road, she will need to have something done on the right side. So if you have 2 stents on the left side, that will make it a very difficult problem to fix. So I'm thinking down 5, 10 years down the road, she'll still be young, she'll be in her 50s. I'll be very surprised if at some point this patient will not develop a problem on the right leg.
Right. So to that point, Windsor, that's an excellent point. It's obviously why I wanted to show this case. I think it's a very good case to sort of talk that through. Probably most importantly, on the right side, the wire was able to go outside the previous stent. So in the future, if we wanted to reconstruct this and do kissing stents, I feel very confident that we would be able to do that if the patient were to need that in the future. I agree with you, there's a high likelihood this patient will need something done on the right side in the future, but that time is not now. And so what I'm trying to grapple with is if we go too high with this second stent, it might make it more challenging to reconstruct her at a later date. So I'm trying to be a little bit more conservative with this second stent to really only treat the left side and not go all the way into the IVC.
I mean, I think your positioning looks perfect right now, Rob.
Okay. Any other comments? Because I think we're going to go. So there's a very, very nice deployment mechanism. I don't know if you can zoom in on Dan's hands or not. I don't know if that's possible, but if we can certainly show the fluoro here. Dan's doing it in a very, very stepwise, slow, methodical kind of way. And I think we really nailed the confluence very well. And I'm going to de-zoom here.
Look at that ISR still.
See the whole thing.
And there you go. All right. So that's exactly where we wanted to land it. I can't think that Dan could have done a better job perfectly positioning that. And then we're going to put back in the 14 millimeter balloon and post-dilate unless somebody disagrees with that plan.
Looks good.
All right. And we're using, again, a high-pressure Atlas balloon. Sorry, we're just getting our sheath readjusted. So any comments? I know Keith alluded to this before about what's the optimum strategy to follow these patients up, therapeutic anticoagulation. Do people have strong opinions about antiplatelet therapy for these kinds of patients now that we placed a fresh stent?
I mean, people are all over the place. I mean,
Totally all over.
Not data-driven, but my personal preference, at least for a short period of time, is dual antiplatelet and Lovenox, and then converting ultimately to oral to complete at least a 6-month time frame.
So these
Totally
stents-
data-driven.
So as mentioned, there is no data out there, and these venous stents, they do surprisingly well, much better than arterial stents. So we don't see as much problem with thrombosis, which is a big surprise. So what I do, I use, I think that the goal here is to prevent thrombosis. So I use a DVT prophylaxis dosage of Xarelto at 10 milligram. And I think usually just the first couple of weeks will suffice. And then I transition them over to baby aspirin. But having said that, there is no data at all. You can literally do anything that you want to do.
And I typically do Lovenox, but I do a single antiplatelet, typically clopidogrel Plavix for the first 3 months, and then I transition them to a baby aspirin unless there's another reason for them to be on full dose aspirin for other cardiovascular reasons.
So I think you saw on that last balloon inflation there was no appreciable waste. And I think that's as a result of a combination of very, very good pre-dilatation and, again, the fact that we have a dedicated venous stent here, which I think is just helping reconfigure this case very, very well. So my plan right now is we're going to continue dilating the length of the stent. We're going to do a repeat intravascular ultrasound, and we'll show that to the panel, to the audience. And then I think we're going to allow you guys to go to the presentations. Does that sound like a good plan?
Sounds great. Nice job.
So while I have you guys as a captive audience, what do you guys think about stenting the common femoral vein? We obviously didn't do that in this case, and I usually try and avoid it. But how are you guys dealing with chronic DVT in the common femoral vein right now?
I think,
Especially now that we have dedicated stents.
I think if you have compromised inflow because there's chronic subtotal or total occlusion of the common femoral vein, and you don't extend a stent at least to the profunda inflow. Well, and I would never extend beyond the profunda inflow or hardly ever. You're just asking for your stent to go down. So the most important thing I think is to avoid a stent joint, meaning the union of two stents at where the fulcrum of the hip is. So I tend to look at that as the crease on the patient while I'm doing the procedure, and I want to try and land the mid body of the stent in that area as opposed to having two stents join in that area.
Yeah, I mean, honestly, I'll do common femoral vein stenting really more applicable in chronic DVT work, and only if it's compromised flow and similar placement as Kush said. I mean, that area right down there is really resistant.
Absolutely.
It's in venous disease, it's permissible to stent across a joint. But I'm really not all that keen in doing it because many of these patients are pretty young, in their 40s and 50s. Putting a stent across a joint space is you inviting problem down the road. But there are situations where you don't have a choice. You have to have good venous inflow to keep open whatever you're doing. So in those exceptions, I would put a stent across the common femoral vein, but it's only on an exceptional basis.
Okay, so we've got the IVUS up. And if we could switch over to the live IVUS feed, please. Thank you. Perfect. All right, so we're going to do a very, very, very slow pullback here. If we could record this also so we can archive it, please. Thank you. So we're obviously up in the IVC, and we're going to slowly pull back down. There's the contralateral wire that you guys can see. That's the original smart stent. And that's the common iliac vein. So there was a very, very mild compression I saw there, but I thought it looked dramatically better than it did before. I hope everybody in the room agrees with that statement.
Yeah, it looks really good.
And then obviously we've stented through all the ISR coming all the way down. And there we are below the stent, about to go into the sheath. So we're going to do a venogram here. And unless anybody has any other comments or questions, I think we're going to wrap up. But, I mean, really, really good conversation. I think we spoke about a lot of contemporary issues regarding venous stenting and certainly how to manage very symptomatic patients. Can we go back to the angiogram, please? Thank you. What do you guys think?
Looks great.
Looks great.
Okay.
Rob, thank you for
I think
a
we're
great
going to close it down here in room one. I want to thank everybody in the room. Thank you to the panel. Unbelievable. And I'll let you guys go to the second session of talks.
I want to make one final point that's really important.
Sure.
When you stent for PAD, the longevity of those patients are pretty limited. They don't stay around for a long time, right? They die from heart disease, strokes. These venous disease patients, they're going to be around for 5, 10, 15, 20 years, maybe even longer. So you need to be very mindful what you do at the present time, because that particular patient will be coming back to you for some additional interventions.
I totally agree. These are our patients for life, and we need to keep a very, very close eye on them. Obviously, this patient has a wound, so they're going to have to get aggressive wound care, but I'm very confident that now that we've addressed the outflow issue, we can focus on the issues that you were alluding to before, which is whether or not there's a small perforator in the calf, et cetera. But again, thank you guys very much this morning, and I'll let you guys get back to the presentations.